Welcome, hello, and greetings to all of you. My name is Konstantinos Donas. I am a professor of vascular surgery, head of the Department of Vascular Surgery of the Frankfurt University Hospital Asklepios Klinik Langen in Germany. Welcome to this non-industry founded webinar organized by the Radcliffe Vascular Group. I am more than glad to have you today here together to speak about a very interesting topic. As you know very well, calcification in the treatment of complex femoropopliteal lesions is very challenging. So we have to have a solution, an option to overcome these challenging conditions. This was the reason why we considered to present you today the topic of the atherectomy. I am more than glad that I have two colleagues who are experts in this field, and I would like to have the opportunity to present you my colleagues. Let's start with ladies first. Assistant Professor Dr. Gergana Taneva is a consultant vascular and endovascular surgeon in Madrid, the research lead also of my center here in the Asklepios Klinik Langen. She will present the option of the rotational atherectomy for the treatment of complex femoropopliteal lesions, and also well known without to have any need for introduction, Dr. Michael Lichtenberg, who is the chief of the Ansberg Vascular Center, will present the other option, the orbital atherectomy, and we will have the opportunity to hear the two talks. After this, we will discuss and have the opportunity to have an interactive discussion. Please use also the box in order to send me questions. And after the discussion, we will have the opportunity to see some excellent recorded, very educational cases in order also to see how perform all these devices in our clinical practice. Based on this, I would like to start the webinar showing the first talk and start with Dr. Taneva speaking about the rotational atherectomy. Dr. Taneva.
Thank you very much, Kostas, and thank you very much, Radcliffe Vascular, for this very kind and very nice invitation. I'm very happy to take part of this webinar, and I think it's very important to go forward in the vascular field, investigating new possibilities and new ways to treat our patients and to offer them better chances to save their limbs. So let's go forward with this. I hope everyone sees it correctly. And I changed a little bit the topic, not the big challenge, but the big solution. And I think it's atherectomy. Let's go over rotational atherectomy. As introduction, as you know, we have to treat endovascularly some very complex lesions, diffuse and complex lesions, including soft and fibrous tissue, calcium, and even thrombus sometimes. And these complex lesions lead to high risk for restenosis if we use PTA alone. Then we have symptoms recurrent, and that's why stenting and drug-eluting technologies arise. However, the use of stenting by itself has some risk, as you can see here, of stent fracture and thrombosis. Here we have some examples from our own clinic where you can see stent fracture, in-stent plaque protrusion, stent hyperplasia, and on the right, an X-ray of the stent fracture. And that's what can happen with stenting. And in this commonly cited study, almost, as you can see, 1/4 of the stent fractured, and this led to some primary patency rate diminishing in the patients, and we had 12-month primary patency rate of almost half than the patients who didn't have stent fracture. According to the International Positioning Document, these lesions, femoropopliteal lesions with de novo restenotic complex lesions, should be treated with DCB, which offers actually advantages over POBR and bare metal stents. We can say here that DCB performs worse in lesions with chronic occlusion. And why remove calcium then? Because it actually may influence drug-coated balloon efficacy. And the plaque associated with arterial dissection, and these plaques commonly have highly calcified lesions. And also, of course, we know that calcium necessitates greater balloon inflating pressure. In this commonly cited study by Fanelli et al., greater calcifications were associated actually with greater TOR rate, lower ankle brachial index, and greater late lumen loss. Then that's what we have. Limitation of the drug-coated balloon is actually long CTO occlusions and severe calcification. And we also saw the limitations of stent advantage to increase the drug transfer to the tissue wall. You can see here that atherectomy removes the atherosclerotic and calcific tissue, similarly actually to the surgical technique, and it results in lumen gain without barotrauma. It also facilitates lower balloon inflating pressure, and that we know that decreases the chance for dissection. As you can see, it can also avoid stent placement following the theory of leave nothing behind, and potentially simultaneously optimizing the delivery of the drug to the vessel wall, which actually has to be studied in the future. We have different strategies of atherectomy. We have directional atherectomy, rotational, laser, and even orbital atherectomy. We'll focus on this talk with the rotational atherectomy and more especially with jet stream atherectomy. The jet stream system is the only one which has active aspiration and expandable blade technology, as you can see here. It has front cutting, which engages the plaque, and also it has concentric cutting with rotational expandable blades, allowing to treat the same vessel with only one catheter. What is very interesting from this device is the active aspiration. It is the only device with active aspiration which can actually aspirate the debris in some thrombus formation. It has differential cutting and only cuts the inelastic tissue, leaving behind the elastic tissue alone. You can see that we have different catheters depending on if we are treating femoral-popliteal lesions or BTK lesions. And when we expand the plate, we have more diameter to involve in the vessel, so we can treat and gain more lumen gain. It is an over-the-wire system over an 014 wire, 7 French compatible, as you can see, and this is the console, some images of the console. The jet stream atherectomy has been on the market since 2008, and it has been evolving and improving over the time. And we'll focus on some literature we have up to now, and at the end I will comment our own study on the subject. This is a prospective single-arm multicentric study of more than 170 patients, and as you can see here, they had more than 99% almost device success, with quite good patency rate at 6 months and at 12 months. And stenting, importantly, was performed only in 7% of the treated lesions. As for the 1-year outcome after jet stream atherectomy, the 12-month major adverse events were of 25% among diabetic patients, and there were almost no differences with non-diabetic patients, and there were not significant. Again, for the major adverse events, there were no significant differences between diabetic and non-diabetic patients. So if we think about diabetic patients as some patients with more calcified lesions, actually there were no differences. What about IVUS in jet stream use, which we actually have employed, are going to study in our clinic lately. This is a prospective single-arm multicentric study, and as you can see here, even if they didn't have so many patients, there were only 26 patients, but the majority of the lesions were in the SFA with very severe calcification, and they used adjunctive therapy in most of them. Most importantly, what I wanted you to see is that there was a significant increase in the minimum lumen area in all of the cases, with significant decrease in the area of stenosis, and the decrease in calcium area accounted for 86% of the lumen area gain. This is an example, and you can see how the area was increasing after jet stream atherectomy use, and there was no dissection. As for the post-market registry, a multicentric registry with 37 USA centers, very impressive, more than 240 patients, again with moderate and highly calcified lesions. They had also some occlusions, and the pretreatment stenosis was more than 90% in the cases. They used 35% of stents in the treated lesions, so stenting rate wasn't high either. And they used embolic protection devices in 22.4% of the cases. The restenosis rate was low, as you can see here, and TOR rate, freedom from TOR, was of almost 82% at 1 year. 70% so didn't have any symptoms or minimal symptoms at 12 months. This is another prospective core lab assessed feasibility registry into US centers. The lesion length was of around 17 centimeters, quite long lesions. And again, the procedure success was high with no new stent fractures. This was an in-stent restenosis study, and they had good TOR rate at 6 and 12 months. Now I wanted to focus on our own registry. We did a prospective single-arm multicentric study of 4 vascular centers in Germany. It was non-industry founded registry, and we had more than 110 patients, as you can see here. More importantly, we treat only occlusive lesions. So all the lesions were occlusive CTO lesions of patients with ROSA from 1 to 5. And we had de novo or restenotic complete occlusions and lesions with lengths of more than 1 centimeter. As you can think of, the patients needed to have more than 1 run of vessel to use the jet stream atherectomy. And our primary endpoints were flow limiting dissection or recoil, a need for stenting, and the secondary endpoint was embolization that requires reintervention. As you can see, according to Fanelli classification, most of our patients had moderate, very highly calcified lesions. The median lesion length was 8 centimeters, and almost 30% of the patients had some thrombotic component. We had 9 cases of in-stent occlusion. These are some examples. As you can see on the left, we have an in-stent restenosis and occlusion, which we treated with jet stream atherectomy. We used filter, and on the right, you can see the final result after DCB. This is another example of PTO-CTO occlusion. We again used a jet stream atherectomy here. We used filter again, and this is the final result on the right after DCB adjunctive therapy. These are our results. We used only 15, employed only 15 stents in all of the patients, all of the lesions, and there was flow limiting dissection or recoil in 18 cases. So you can see the low, relatively very low incidence of stent placement, despite the fact that we were treating CTO lesions. And we also had some low incidence of embolization due to probably the aspirating capacity of the device. Here, more importantly, after univariate analysis, we saw that lesions of length of more 8 centimeters in combination with Fanelli 3 and 4 associated actually significantly with flow limiting dissections or recoil and need for stenting, which means longer lesions with higher calcification associated with recoil or need for stenting, which actually is something logical to think. But then we also saw that localization of these lesions at Hunter channel that associated with almost 5 times more risk for flow limiting dissections and need for stenting. As conclusions of this presentation, I would say that the stem pop lesions are complex, are very challenging, and very often calcified. The presence of this calcium may limit the effectiveness of DCB, and it increases the dissection risk. Then vessel preparation with atherectomy actually beholds biological advantages and mechanical advantages. Debulking the plaque enhances the drug transfer to the arterial wall and aspirating the debris, preventing embolization. The use in these lesions seems to be safe and effective, and it increases swimming area while improving calcium, while possibly decreasing the stent placement as we saw in our IVUS images. Finally, the directional atherectomy for the treatment of femoral lesions can be effective, modifying the plug and removing the calcium, leading to increasing lumen area and improving DCB effect and lowering complications, which is actually what we want for our patients. So this is all about the presentation. Thank you very much.
Yeah, thank you very much also from my side for this invitation today. Would like to thank Radcliffe for setting up such a very interesting and very important session on lesion preparation. Great presentation, Dr. Taneva, on calcium burden lesion treatment. I will, in my presentation, now focus on the orbital atherectomy approach. You discussed, Dr. Taneva, already a lot about calcification. I would like to discuss a little bit more on the lesion preparation itself, not only focusing on calcification, but also on the issue that we should think about the proper lesion preparation. We know that conventional balloon angioplasty, and you can see this here on this video, has many, many drawbacks. We know that this torsion on intima creates dissection. So standard balloon technology is associated with a lot of complication. We are talking about insufficient lumen gain. We are talking about recoil, barotrauma. So the flow limiting dissection force us to implant stents. So we are talking also about bailout stenting. So therefore, I think we need to discuss on lesion preparation, also not on the calcification side. We should discuss about improving vessel compliance. And I would like to focus on that a little bit during my presentation. So why debulking? It removes the barrier mechanically, no overstress, regardless which atherectomy, which lesion strategy with atherectomy device you use. With that, we have the chance to apply low pressure balloon angioplasty to the vessel wall. So we are not talking about a barotrauma with 10, 12, 14 atmospheres, just with a few atmospheres. With that, we have the chance to avoid stent implantation and can follow, as you already, Dr. Taneva, mentioned, leave nothing behind. Yeah, this preserves bypass landing zones, of course, especially in the distal SFA or even in the popliteal of the segment 3. And this keeps options for different therapy strategies in the future. And therefore, I would say, let's not only talk about calcification lesion treatment, let's talk about lesion preparation in many indications. So here's a typical case example. As I would like to emphasize the compliance change. You could see here on the right side an SFA in the proximal or popliteal segment. You could see here in the proximal popliteal SFA area, there is a high-grade stenosis, and there's also high-grade stenosis in the distal popliteal area. In the proximal part, we just performed no atherectomy and gave atmospheres of 8 atmospheres with a balloon to the vessel wall. This caused a very severe dissection, as you could see here on the magnification. In the distal part, where orbital atherectomy was used, there was no dissection seen because only low pressure atmospheres was applied to the vessel wall with force at 4 atmospheres. That means with improving compliance, we have the chance to avoid dissection and to avoid stent implantation as a bailout strategy. I would like to focus a little bit on the orbital atherectomy, as we have already seen now the rotational atherectomy devices. So this is the Shell 360 orbital atherectomy system from CSI. This is the equipment which comes with the technique. It is first of all the pump, which we'll show you in a second. And then you see the Shell 360 atherectomy device, which is available in different sizes. I will also show that in a second. So there are different sizes of the system available, talking about different crown options. You can see here on the left upper side a micro crown, classic crown, and sonor crown. And you could see the configuration of these crowns. These crowns can be chosen based on the lesion, on the diameter of the vessel. So you can choose always which comforts best for the individual lesion. Here's a closer look at the different crown sizes. So we are talking about a solid crown. So this is for maximum calcium removal. This is something that Dr. Taneva just showed us with severe calcification. The classic crown is for vessel bands, osteal lesion, and distal BTK procedures. And the micro crown on the right side, this is something very new and interesting. That's especially for tight bands below the knee. With that, you can even go down to the dorsal pedal artery if you want to. You could see you could run these crowns with different speeds, low, medium, and high, which is on the lower part here of the slide, up to 100,000 rounds per minute. And with that, you can really create great lumen gain and perform a very well lesion preparation. Here you could see which crowns fits best in general for the different sizes of the vessel. So the crown sizes are shown here. So the typical size I use for the SFA is a 2.0 solid or classic crown. The more distal you come, then I use a 1.5 solid crown or 2.0 classic crown. For below the knee, especially for very distal pedal interventions, you can use the 1.25 micro crown. And what I can tell you, very soon a 1.0 millimeter micro crown will be available so that we can even discuss and use this device for pedal loop interventions. So here's a typical case example I would like to share with you. So this is a case example of a popliteal artery calcified lesion. Is it running, Kostas? I don't know.
Now, yeah, we have.
Wait.
Yeah, we can see it.
It's running it now?
Yeah.
Okay. Oh, interesting.
But now you. No, now you.
Now it should run, huh?
Yeah.
Yeah, you
see here. Running.
Please?
It is, yes.
Yeah. You see here popliteal area where we use the 1.5 micro, the 1.5 crown system here to perform a lesion preparation in the popliteal artery. With that here, you can see and move forward the system very slowly through this high-grade calcified lesion. And after using this, and just performing drug-coated balloon angioplasty, we had a very good result at the end. There was no dissection, no significant recall, and therefore no indication for stent implantation, as you could see here also on different angulations. That means with that we improved the vessel compliance. Yeah. With that, we only need 4, 5, 6 atmospheres for drug-coated balloon angioplasty, and with that, no dissection or remaining stenosis. So the question, of course, do we have data for that? Yeah, and we have data. We have these data here from different CSI studies. Here, I summarized the especially important aspect of vascular preparation and also of maybe complications. So perforation was no issue in all these SFA and BTK trials. I will go into more detail in a second in 2 trials. So no perforation. There was no flow-limiting dissection after atherectomy and, of course, balloon angioplasty. There was no significant embolization, and Dr. Taneva and Kostas, we could discuss about embolization complication and especially also on slow and no reflow issues after this. There was no issue of that seen in these trials. Let's dive a little bit more deeper in 2 of these trials. This is the calcium 360-degree trial. It's a comparison of orbital atherectomy plus balloon angioplasty versus balloon angioplasty alone in patient with critical limb-threatening ischemia. So very interesting setting. It was a prospective multicenter randomized trial with calcified BTK lesions. So 50 patients, one group, orbital atherectomy plus PTA versus PTA alone. Not a very big patient population, but I think a very interesting setup. On the right side, you see the demographics, typical CLI patient with diabetes, renal insufficiency, and so on. Here you see the lesion characteristic itself, the number of lesions, lesion length, of course, not that long, below the knee. We're talking about below the knee, so not that long. But most of the lesions with moderate or severe calcification. You see the treated lesions mainly in the tibial arteries. And when we now look at the results, I think this is something very interesting, that the mean maximum balloon pressure, which was necessary to achieve a good lumen gain, was significantly higher in the PTA alone group with 9 atmospheres versus 5.9 atmospheres in the combination therapy group. And when we then look at the results at 12 months, you could see especially at freedom from major adverse event situation, there was a significant difference between the combination lesion preparation and versus the PTA alone group. In terms of freedom from revascularization, there was a clear trend, not significant. But freedom from major adverse events, which of course included also major limb amputation, there was a significant improvement of that combination therapy. Let's bring it to the SFA and popliteal artery with the compliance 360-degree study, which was also a randomized prospective pilot multi-center study comparing acute and long-term results of orbital atherectomy to standard balloon angioplasty. Also, setting randomized control trial, 25 patients in a combination group, orbital atherectomy plus PTA versus PTA alone. Demographics on the right side, I think not so very interesting. Here are the angiographic calcium score analysis. I think very typical for an all-comer situation. Also very calcified lesions were included here in this randomized trial. Let's have a look now on the results. Again, mean max balloon pressure, significant, highly significant difference between combination therapy versus PTA alone. You can see here 4 atmospheres for the combination therapy versus 9 atmospheres in the PTA group. That leads to an adjunctive stenting in the PTA alone group, highly significant more than in the combination group. And I think that is that important aspect here, avoiding stent implantation with compliance improvement. At the end, patency rate at 12 months, no significant difference. But if we take that argument to preserve future options, I definitely would think that avoiding adjunctive stenting is the main argument here in this setting. They also performed an economic analysis in this trial, and even that, of course, an orbital atherectomy approach is a costly therapy. They found at the end that there was a high cost effectiveness ratio for the combination therapy in comparison to standard balloon angioplasty. Also from the economic analysis, a clear argument for combination therapy. So we are talking at the end about a vicious circle which we would like to interrupt, because in our daily routine we are just using standard balloon angioplasty, which creates a lot of issues in terms of dissections, of payload stenting, with then multiple reinterventions of poor long-term patency. Therefore, I personally believe we should interrupt this vicious circle, and therefore I think we definitely need to focus more on lesion preparation based on morphology, not only on native vessels, also for instant restenosis, and as Dr. Taneva showed us, in very severe calcification lesions. When we then perform after the Debarkis strategy, DCP approach, we can at the end only end the case with a spot stent if we need to, like a whatever attack device or an ultra short stent. But definitely we can avoid with this lesion preparation approach using atherectomy, avoid long stent implantation. With that, improve maybe the clinical outcome of our patients. Thank you very much.
Great. I hope that you can hear me now.
Now we can hear you.
Yeah, nice. So first of all, I have to express my deep thanks to both of you. It was really outstanding talks we heard. and we realized why should we perform atherectomy. And I think it came very clearly from both presentations. The main benefit is to avoid or to minimize the need for stent placement. And this is very important, especially as you showed us, Dr. Taneva and also Michael, the lesions, especially in the popliteal artery. So we know very well that we have a significant friction, especially in this area. You have the risk of stent fractures. You have the risk, as we saw from the very nice IVUS imaging. We performed this here in my center for first time in Europe with a new OptiCross 18 catheter from Boston. We realized how is the lumen surface. We saw calcifications, plaque protrusions in the stent, and everybody who has experience knows a stent occlusion is very demanding to be recanalized compared to a reoccluded native SFA or popliteal artery. So we heard and we realized the different options. I think this is very important to learn from your experience. I would like to ask you first, Dr. Taneva, you showed us the rotational option. We have also the Phoenix atherectomy, which is also a rotational option. You showed us the option with a jet stream device. You highlighted the possibility to also aspirate thrombotic components. This is very often in CTO lesions. Can we give us an advice if we want to start and learn this system? Which kind of lesions would you recommend to treat by this device? Should we use a filter? You showed us in the popliteal artery the option of filter. Which kind of tips can you provide us?
Thank you very much, Kostas and Dr. Lichtenberg. Very nice talk as well, and very nice questions. This is actually the clue, right? Where should we start from, and which lesions should we start from? Well, first of all, we have to know that to use atherectomy, we have to cross the lesion. So we need to make sure we are intraluminally. Then if you have crossed the lesion, and if you have in the beginning a short lesion, then it's a good option to start using it, especially in highly calcified lesions, and especially if you do not want to place a stent in this portion. For example, like Dr. Lichtenberg said, in the popliteal lesion. And also, I think it's very interesting, maybe further in the knowledge of these devices, the treatment of BTK lesions, because we don't have so many tools to use in BTK arteries. They're very challenging, very demanding, small arteries, highly calcified, especially in diabetic patients. And then we can only use PTA or DCB, which actually doesn't work so well with calcium. So this is a very nice option as for indication in BTK lesions. From the beginning, if we start knowing the device, I would start with short lesions that we can cross easily. And in the beginning, what we saw from our center is that we use the filter in all the cases. When we gain some confidence in the device, we stopped using it so often, especially with the jet stream device, because it has the aspirational activity. So we were more safe. We felt more safe without filter.
Excellent. You gave me pass now to ask Dr. Lichtenberg, because you pointed out the BTK issues. So in my experience, especially in the BTK lesions, we have very often recoils. We have very often, especially in diabetic patients, we are performing balloon angioplasty, and the patient is coming within a few months, and we have recoil. So from the theoretical point of view, I see more indication to use atherectomy in BTK lesions in order to modify the plaque and minimize the recoil, which is very often in BTK lesions. On the other side, dear Michael, we have, as you showed and you highlighted also, small vessels. So theoretically, I can have more risk for rupture, more risk for distal embolization. So now, can you give me, from your huge experience with all the systems, I would say, with atherectomy, and based on your huge clinical experience, how is your decision making? Which kind of lesions, especially in the BTK area, should be treated by atherectomy? You showed us the 125 micro, which is really a very flexible and very nice tool. But which kind of lesions would go for atherectomy? Which kind of lesions we would say better is to avoid in order to minimize the risk of complications?
Yeah, you pointed out very well, and thank you for that question, that BTK, there's a complete different role. We are talking about small vessels, calcified lesions, calcified vessels, especially media calcification, and we are talking about not proper visuality of these vessels. You know, we have bone overlap, we have that calcium, and it's very difficult to really assess the morphology of such lesions. And this makes it very difficult. Of course, we can just bring a wire in, balloon the lesion, but at the end we have dissections and we have recall. I would like to remember a publication from, I think it was 2013, from a Swiss group from Baumann, who performed an analysis of recall after standard balloon angioplasty in BTK vessels. And what we saw in this great paper, and this was the only paper so far as I can remember, that after 15 minutes, so just 15 minutes after balloon inflation, there was a highly significant recall with a loss of lumen more than 50%. So what does this mean after 4 weeks, a couple of weeks later? And therefore, I really would like to advocate to create a stable lumen. And the stable lumen is not achieved with standard balloon technology. I think we need to do something on the vessel morphology. If we need to do this with atherectomy or scoring device, I don't know. We do not have any direct comparison of different techniques. But I personally believe, and I think we have now more and more evidence, that we should do something different than standard balloon angioplasty to create, not only create a good lumen, but also to preserve that good lumen. And therefore, I think CSI is an option, of course, but there are also different devices on the market which you can also use. The real advantage of the CSI device is that you can dive very distal with this 125 millimeter crown. So really going down even to the plantar arteries, to the pedal arch, if you have at least have a 1.75 or 2 millimeter vessel. There are not so many devices available which can work here, and it is a very easy to use device once you get some experience with that device. And therefore, I personally see at the moment not so many devices which can really attempt on these very challenging lesions, for a very peripheral situation.
So you highlighted very nicely, and this is, I think, the clinical experience from everybody, that we have the benefit of modification of the plaque, especially in calcified and severe stenosed vessels. On the other side, this is the clinical impression, but we need evidence. We need more evidence. Dr. Taneva, I congratulate you for your professorship in Madrid University. You're very active in the research field. So how can which kind of evidence we need in order to provide these important clinical benefits, as Dr. Lichtenberg highlighted, but also from the scientific point of view?
Well, that's an important point, Kostas, and it arises in every seminar, in every conference and congress. We don't have so many papers on this, and especially not with enough evidence and enough significance, not with enough N number. So we do not need more evidence. We do need more comparison. We do need to know if actually atherectomy works in comparison with PTA and in comparison with DCB. This is a direct comparison which hasn't been done up to now. I think the companies are thinking about doing it, but still the evidence is there. We think that we need more, but nobody actually seems to be so interested in it to perform it. We are aiming to do some studies in the future, our company, and to see, to evaluate it with IBUS and to compare actually what we have at the market and atherectomy. And it seems to work very nicely, but up to now, the evidence is not so robust. And I think that's why some people go behind some policies of no reimbursement, and they don't use it actually because there's not so much evidence.
Before we go to some tips to minimize the risk of atherectomy, which are injury of the vessel, peripheral embolization, we have one question about rotational and orbital. Can we provide an information about the indication for the one and the other options? Which lesions can be treated by rotational, which lesions can be treated by orbital atherectomy? I think you showed us very clearly in your presentations the different characteristics and features of each device, but I would like to hear from you which kind of lesions can be treated by rotational atherectomy, especially by the Jetstream, Dr. Taneva. Calcified, thrombotic components, in-stent lesions. Can you give us some information about this? And after this, Dr. Lichtenberg, also to hear from you which kind of lesions you would treat per se with orbital. Dr. Taneva?
Yes. Concluding, I would say on this topic that we would use in highly calcified lesions once you have crossed the lesion. In-stent restenosis, once you have crossed the stenosis and all the occlusion, because you need to be over the wire and you need to be safe that you haven't gone within a strut of the stent. And also, very nicely, this device works on acute and chronic occlusions, especially because of the aspirational capacity of the device. So once you have crossed, you can use it on acute and chronic occlusion, like thrombotic component on some calcified lesions, which is actually very nice because sometimes we are afraid to perform some thrombectomy on these lesions because of the dissection capacity of the lesion.
So actually in all lesions, as you presented. Okay, Dr. Lichtenberg, can you provide good indications for orbital? When should we avoid it also? It is important to know from your experience.
And let's start with avoidance first to have a difference here. So fresh thrombus, definitely no indication. I think it's also not a good indication for rotational, except Rotarex, of course. In-stent restenosis could be challenging for CSI. This is also off-label use because there could be an entrapment between, or let me say, an interrogation with the orbital crown and the stent struts itself. So this could only be done to create a channel within the in-stent restenosis. So this is definitely not that good. Jetstream definitely has a good indication here also from my perspective. On the other hand, we have the same indications like Dr. Taneva just mentioned for the rotational atherectomy. So calcified lesions, fibrotic lesions, short lesions. And there are very interesting, let me say, scientific data that orbital atherectomy also, let me say, improves media calcification because it could dive very deeply into the media. The intima is decalcified, and then the orbital system also reaches into the media to improve the compliance of the media calcification. So here on this plaque situation, I think it's quite similar.
So you mentioned very often the word lesions. We saw in your talks also that there is different size of the catheters. So I can imagine that probably it's beneficial to use these devices in occlusions than stenosis, because theoretically, due to the fact that you have a size, but it doesn't mean that you can perform for the entire vessel lumen diameter, probably I'm expecting to have more benefits in occlusions than stenosis.
It really depends on the size of the crown. And with the increase of the speed, up to 100,000 rounds per minute, the circuits get bigger and bigger. always. Yeah, this is I don't know what the name of this physical law is, but this is the principle behind that system.
Yeah, centrifugal.
Essentially, it's some kind of centrifugal.
But if we have a non-industry sponsored webinar, and I want to highlight this because it's important to highlight this. Sometimes, however, dear Michael, I am with my colleague here, Dr. Abu Bakr, and when we are performing the atherectomy, you are doing the control angio, and after you see the angiographical result, you say, should we expect, with other words, a huge, how can we evaluate the impact of atherectomy angiographically? Because as you mentioned, there are 2 millimeters the crown diameter. So if I have a 6 millimeter, what I'm expecting to see in order to realize that it works? Because I think if someone expects to perform atherectomy and after the angio to see suddenly a huge lumen, probably will be disappointed. So
I fully agree, and this is the difference. And but here's the difference between these technologies. With this vessel compliance improvement, I think that is maybe much better with the CSI orbital atherectomy system. You can then just apply a few atmospheres of balloon angioplasty to this just prepared vessel. And with that, it suddenly opens like that, and you create great lumen. This is what you see after 2 minutes of 4 atmospheres or 5 atmospheres.
Kostas, actually, in that field, I think IVUS evaluation would be the appropriate to see what we are doing there and what is the lumen gain. And we have seen that as you said, chronic total occlusions, the lumen gain is much more significant than in stenosis.
Yeah.
The crown or the device has the diameter that it has. It doesn't have bigger diameter. And since it goes over the wire, you're going to gain only the diameter that it allows to gain. Furthermore, you need to use, as Dr. Lichtenberg said, some other devices like PTA, DTB to gain some more lumen. But actually, IVUS is going to say what we have done and performed in this vessel.
Yeah, and I think this is a very important aspect with these IVUS guided atherectomy plus whatever afterwards.
Yeah,
I think IVUS guidance in these, especially long lesions. We're not talking about the CTO. We're talking about long serial lesions. We could learn first of all about the proper sizing of any strategy. We can learn about correct vessel diameter. We can learn about lumen gain. We can learn about the morphology of the lesion. We can learn, did we at the end have some dissections left behind? So I clearly see a lot of advantages of a combination therapy, meaning IVUS guided atherectomy plus DCB angioplasty. Because with that, I personally believe we can even achieve better lumen gain and more stable lumen.
I fully agree with both of you. I think IVUS should be the future of evaluation. I heard you said very nicely in one webinar, luminography is actually what we are seeing the angio. And I had one case with arterial embolization, and angiographically you thought, okay, middle grade stenosis, not big deal. But when we saw with the IVUS the plaque morphology, we realized that the embolization came from this popliteal lesion, which was angiographically unsuspected. Yeah. I think this is an excellent tool, and I'm more than glad that we have it here, and we should have in a routinely use. You can imagine how many questions I'm receiving. I have one question which I like to highlight. How to know when you are subintimally, and if you are subintimally, you recanalized, you checked that you are intraluminally at the end of the occlusion, and then you decide to go subintimal, then you decide to go for atherectomy. But you can be in one segment subintimally. Should we do it? How can we avoid it? This is a very good question. I want to hear your opinion about this, especially in long lesions. I would say it's difficult. Dr. Taneva, would you like to comment on this? How can we?
Of course, it is difficult to go intraluminary, especially in highly calcified and complex lesions. And at some point, you can go outside or perform a spheroidate in spiral dissection of the vessel, and this is difficult. But of course, you need to have intraluminal gain again with the wire distally. This is the point.
So another advantage of using IVUS actually to prove where you are with the wire.
Yeah. What I saw in my experience was I was in one segment subintimally, and then I learned that at least for the rotational atherectomy, it doesn't rotate if you are subintimally because it doesn't have probably the space to rotate. So actually you are not going, it's not going to work. And if it is clear that you were subintimally when with some tricks you came intimally, I would avoid to use at least rotational atherectomy because you are not going to have the benefit of this. The benefit is if you recanalize it intraluminally and then to modify the plaque. I have one question for you. We wanted to see the recorded case, but you see the discussion is very, very nice. And one colleague asking us, can you please repeat why orbital atherectomy affects medial layer calcification?
So this is not, let me say, evidence. Yeah? It is something we learned from bench tests where we could see that, especially with increased speed, the crown also dives into the media, improves here calcification. I can't support this with any clinical data. The problem is, how do you want to prove that? You can only prove it with an IVUS guidance.
Again,
so it should be an IVUS analysis study. So at the moment, let me say it's an hypothesis. Yeah.
Okay. So in a summary form, we can say that IVUS is probably the best diagnostic tool to evaluate the impact of atherectomy in general, to realize which is the impact and how influence and modify the plaque compared to the standard radiographic evaluations.
Especially also below the knee, I would say. Yeah.
Especially below the knee, yeah. Yeah, I think we had a really nice overview about the therapeutic options. A few words, dear Michael, about directional atherectomy. You have also experienced, there is another tool. When do you see benefits for the directional atherectomy option? And you can mention the 2-3 options which we have.
Yeah, when we are talking about evidence, then we are talking on evidence on a trial, definite IR trial from Thomas Dallow using directional atherectomy, so the Hawk system plus DCB angioplasty, where you could show that this combination therapy had some benefits in terms of preventing restenosis and better clinical outcome. But this was also just a pilot. What is clear, whenever you're talking about directional atherectomy, you're also talking about embolization issues. So a filter is necessary, not only in the Hawk system, but also in the OCT directional atherectomy system, like the Avenger devices, like the Panteris device, which is available in 6 French and 7 French. So with the Panteris device, you can also treat below the knee disease with the 6 French Panteris device. And the very interesting aspect of this device, of the Panteris device from Avenger, is it has an OCT technology embedded. So with that, you can clearly see what you are debulking. You could see even much better than IVUS could show you what is the lesion like. You can see the structure of the lesion. You can definitely clarify on the morphology of the lesion. And then you can, in a 360-degree, look around and say, okay, I have to work more eccentric here, more eccentric here. So very interesting technology. You could, as you could see, with a highly clear clarification what you are treating. And I think this is a very interesting technology.
Dr. Taneva, last comments from your side. Would you like to wrap up to present us the conclusion of this webinar? I would like to close with your summary of the very, very important educational webinar from today. Would you like to?
Thank you very much, Kostas, and thank you very much, Dr. Lichtenberg. It was very nice, a very nice summary, a free webinar on atherectomy. And I think we summarized some of the important points, and it is going to be the future, in my opinion, of the endovascular tools and endovascular treatment in ephemeropopliteo and BTK lesions, because we actually do need more things, more tools to use in these lesions. So I think we are going to develop strongly in that direction.
Great. Last but not least, I would like to express my deep thanks again to Radcliffe Vascular for the organization of this webinar focusing on the atherectomy. We will have the opportunity very soon on demand to see again the important presentations and also the very fruitful discussion. I had a very good feedback from the audience with many questions, which shows that especially at the end, if you sending so many questions, it means that it was a very live, very empathic webinar. You see, we have an excellent afternoon and sunny day here also in Germany. I'm more than glad that we can join now the rest of the day. Again, I would like to thank you, both of you. It was a big honor to have you in this panel to support my idea to focus on this very promising, as you highlighted, Dr. Taneva and Dr. Lichtenberg, therapeutic modality for the treatment of our patients. Thank you very much, dear audience, for watching us. Thank you again.
Thank you.